Hello, everybody. My name is Dr. Mohammad Saif Khan, and I'm a consultant in ICU at King Hamad University Hospital, Bahrain, and also the program director for Saudi Fellowship in Critical Care. And today we are going to speak about a nice topic which could be asked in exams as well as in interviews, and it should be known to all anesthetists, at least introductory part. Okay, sometimes they may ask you a particular scoring system, but you should know, you should have an idea about the utility of severity scores and what are the main severity scores which we use in ICU. Okay, so let's start. So by the end of this lecture, you should be able to know the purpose of ICU severity scores, why do we use it, and then we will do some comparative analysis of major severity scores and try to apply the scoring systems in clinical scenarios. And also we will discuss the limitations of each score. So this is a clinical scenario for all of you. A 65-year-old male with a history of COPD and type 2 diabetes mellitus is admitted to the ICU with severe community-acquired pneumonia. On admission, he has the following parameters. The BP is 88 over 50, heart rate 118 beats per minute, respiratory rate 28 breaths per minute, PaO2 upon FiO2 ratio 180 millimeter of mercury, serum creatinine 2.4 milligram per deciliter. It has increased from the baseline, which was 1 milligram per deciliter. Glasgow Coma Scale 10, E2V3 M5, arterial pH 7.25, lactate 4.2 millimole per liter, and WBC 15,000 per millimeter cube. So with this available information, which of the following ICU severity scoring systems would best predict this patient's in-hospital mortality risk? APACHE II, SOFA, SAPS III, MPM III, APACHE IV. So various scoring systems are listed here in these options. So these kind of questions may come in as an MCQ for super specialty, NEET super specialty exams for anesthesia or critical care medicine, and also could be asked as a separate short notes in exit exams for DNB and MD anesthesiology. So this is why we should know. So this is from exam point of view, but still, if you are working in ICU, you should have an idea about the severity score. So why you should have an idea? Why should you? Why should know what is the utility of severity scores in ICU? So the main utility, as you know, is to know the severity, how sick the patient is. How will you tell the family or your colleague in ICU that a patient is sick objectively? One way is the subjective way, like a clinician who see the chart of the patient, the values on the monitor and the ventilator and various inputs from the patient, the parameters and history, etc., and then decide how the patient is, how sick is the patient. So that is one way. That is clinical judgment. Okay. So that is quite vague. This is why we have to have a value, and this value has to be obtained from calculation of severity score. So this is why we should have a severity score, at least to tell you how sick the patient is and what are the chances of this patient to survive at the ICU discharge. Okay, at least. So the mortality. So that is one more important, or you can say the most important function of severity score is to predict the mortality risk in the percentage, and that is called predicted mortality risk. Okay, so or the estimated mortality in the percentage. So there are particular scores which are validated to be used as the mortality scores like Apache 2 and SAPS 3 and even Apache 4. So even MPM. So we will know about these scores later. So this is the first and foremost role of the severity score in ICU to tell the patient's relative, at least during your discussion with the family, that this patient is having the risk of mortality of about 70% today. And then these are the options, okay? And if the patient has chronic health disease status like cancer or a terminal disease which cannot be cured, then you can discuss the palliative option as well with the family. So this score is going to help you in the family meeting. Then other sets of score will be able to tell you about the degree of organ dysfunction, how severe are the organ failures. Okay, so combined score. And most common score is, most common severity score which we use for this purpose is a SOFA. So we will know about SOFA later. And suppose you know that this patient is very sick, but is young and has high chances to respond to the treatment which you are giving in ICU, then you need to, decide about the resource allocation. Resource allocation means that you need to devote more staff to that particular patient who is sicker but has of higher chances of coming out of ventilator or coming out of ICU. Okay, disease wise at least. So then you can allocate more resources, more 1:1 nursing, and you can plan aggressive therapeutic interventions. For example, you can put a central line instead of external jugular vein for the vasopressors. And then even you can go ahead with a more aggressive option like ECMO or extracorporeal life supports and also CRRT. So all those aggressive measures of treatment and the therapeutic interventions can be instituted in a patient who has a good prognosis and is young. So those kind of decision making can be guided by these scores. Okay. And also it has a role in research. Suppose you want to compare one ICU with another ICU, the population wise. Then you can compare using the Apache 2 and using the SOFA scores. Okay, so that you can compare different ICU populations in the research. Okay, that okay, that ICU had sicker patient. Our ICU has more sick patients. Okay, or less sick patient. Like that, you can have an idea about the severity of the illness in that particular group in the research arena. Then it also can be used as a quality improvement. For that purpose, you need to calculate something called standardized mortality ratio, which is basically predicted upon the actual mortality, that is the ratio. And suppose this ratio improves over the time in particular ICU, that means that ICU is having good performance and is improving. So as an improvement indicator also it can be utilized. So these are various reasons why we should know about the severity scores in ICU and why we should calculate. See, the calculation is quite difficult and it is a practice. It has to be in the practice. It has to be in the policy. And for policy makers, it is important to know that what is the Apache 2 of the overall ICU over a period of time. Okay, so that will also help for the policy makers to rationalize the resources to ICU. Okay, so it has a value for everybody, for the patient's family, for the doctors, for the policy makers, for the hospital administrator. Everybody should know how sick the patients are in ICU. Now we should know the types. Okay, this is very important. So broadly, we have two types of ICU scoring system. One is the mortality prediction scores or severity scores, and the other types are the organ specific, like organ dysfunction scores. So the general ICU mortality and severity prediction scores are Apache, SAPS, and MPM. So at least you should know the name. So